Good afternoon, Parapups. Welcome to our lecture on immunology. Immunology is a really interesting topic as it involves a number of aspects of the human body and how it reacts to different aspects of both things from uh, the immune system and regarding to a foreign substance, all the way up through allergic reactions and anaphylaxis, which can be a true life-threatening emergency. So we're going to spend some time talking about the importance of understanding of how the body reacts to specific antigens and pathogens and things that can trigger an autoimmune or immune response. Let's go ahead and get our lecture here underway. So when we think about an allergic reaction is an exaggerated response by the immune system to a foreign substance, something that's not supposed to be there, that's triggering a massive response generally, or even a localized response, depending on the severity of the exposure. And that foreign substance that is going to be there can really range from anything from a mild skin rash to a severe life-threatening reaction that involves the entire body system, organs, the circulatory system, leading to things like shock and even death if left untreated very, very quickly. Now, the most severe type of allergic reaction is anaphylaxis, and we should remember that from our EMT program. Now, anaphylaxis is a true life-threatening emergency that requires prompt recognition and specific treatment by paramedics. We have to make sure that we recognize it, that it is crucial for us to intervene. The emergency treatment of anaphylaxis is one of the areas in pre-hospital care in which advanced life support really makes a difference between life and death. It really is important for us to recognize that. It's also important for us to be able to understand that anaphylaxis can develop within seconds. It can lead oftentimes over a period of time, but generally true anaphylaxis is going to have an onset within just a matter of seconds, and that can cause death in just a matter of minutes after an exposure to whatever their offending agent or trigger agent is. Now, fortunately, there's a lot of medications that are available for us to be able to reverse these things. Just as some interesting facts, when we think about anaphylaxis, it's going to result from a specific exposure to a particular substance that sets off a biochemical chain reaction. In essence, this chain reaction can ultimately lead to severe anaphylactic shock, a form of distributive shock, and then ultimately to death. Now, the exact incident of anaphylaxis is unknown, so we don't understand exactly how everything happens or why it all happens specifically the way it does, but an estimate, we know that somewhere between 400 to 800 deaths occur annually in the United States, so that's a good chunk of people who die because of anaphylaxis. Now, your most common area that you're going to see where folks are going to be basing on specific reactions are going to be based on exposure to injected penicillin. Yes, believe it or not, we still use penicillin quite a bit. Even though we don't see it routinely used any longer, we use things like augmentin or erythromycin or a number of other different forms of offspring of penicillin. Penicillin is a very common trigger for an allergic reaction. The second one, bee and wasp stings. Those are probably the most two common fatal forms of anaphylaxis. And you're going to look at anywhere between 100 to 500 deaths that can occur each year based on the administration of penicillin, so the peritoneal administration or the injection of penicillin. So those are all some interesting components that you can see. Now, you're going to find about 25 to 40 people die a year based on bee stings or wasp stings. So the long story short here is that you're going to see these, and your ability to react and understand that it is an anaphylactic reaction or an allergic reaction or where it falls in that spectrum is really, really important. But we know anaphylaxis is that most severe aspect of it. We know that anaphylaxis can again develop within seconds, and our most common exposures that we would see or the offending agents are going to be things like penicillin, wasps or bee stings, shellfish, peanuts, plants, and then medications as well too. Those are probably some of the more common ones that you'll see. As we talked about before, we know that anaphylaxis is one of the most severe forms that we have of an allergic reaction. Again, it can be reversed, at least some of the side effects can be reversed if we are very focused on providing the appropriate emergency treatment. Out of the two primary medications we see for anaphylaxis, so we have epinephrine 1 in 1,000, going to be administered between 0.3 to 0.5, typical protocol say 0.5 milligrams IM. You may see your book refer to it as sub-Q, but IM is now the preferred route. And then we're also going to go ahead and make sure that we follow that up with Benadryl, our antihistamine, right, or diphenhydramine at 50 milligrams. You may see doses anywhere between 25 to 50. Protocol will typically say 50, and that's important. And we'll get into the specifics of why those two drugs are so critical, and why the order of administration really does make a difference in stopping the reaction from progressing, and then continuing to get any of the underlying issues, in essence, the histamine, which causes all these distributive problems out of the system. So when you think about the immune system is the principal body system that's involved in allergic reactions. It does focus on other body systems as well, but we're going to really focus predominantly on the allergic reaction aspect of it. The areas in which it can involve include things like the cardiovascular system, the respiratory system, the nervous system, the gastrointestinal system. That's a key. I'll tell you a story about that a little bit later. And then among others that may present. Now, to be able to fully appreciate the complexity of the allergic reaction, from an allergic and anaphylactic reaction, it's first necessary to review a lot of the anatomy and physiology of the immune system and how it relates to the immune response. This can get kind of complicated, but we have to recognize, one, it's a principal body system that's involved with allergic reactions. We know it's also responsible for infecting, or not infecting, but for combating infections. And then we also see components of it that are found in the bone, marrow itself, the bone itself, and then also throughout the lymphatic system. All right, so let's think about some pathophysiology here when it comes to the immune system. The immune system is a very complex cascade of events that occurs following the activation of an invading substance. We often refer to that as a pathogen. Also, sometimes we'll refer to that as an antigen as well, too. I'll get into that here in a second. Now, the goal of the immune response is the destruction or the inactivation of these pathogens, abnormal cells, or other foreign molecules, toxins, whatever's in the system that's causing this reaction. The goal is to be able to eliminate that. Now, the body can accomplish that through two primary mechanisms. The first mechanism that you see is cellular immunity, and the second is humoral immunity. Now, cellular immunity involves a direct attack on the foreign substance by specialized cells of the immune system. Now, these cells are particular because they physically actually engulf and deactivate or destroy the offending agent, right? So these are going to be different components like your macrophages and things like that. They're going to come and they're going to gobble up and destroy it. Now, when we think about humoral immunity, on the other hand, this is much more complicated. Humoral immunity is basically a chemical attack. It's a chemical attack on the invading substance. Now, the principal chemical attack agents are going to be antibodies, right? There's a lot of talk about antibodies right now because the pandemic and COVID-19 and the different variants that exist. But this cascade really has a major impact. And the difference between cellular and humoral immunities is the use of antibodies, right? Humoral immunity is going to be the main thing that you're going to see. Now, those antibodies are also referred to as immunoglobulins, or IgS, or Igs as I refer to them, right? And there's a ton of them. There's IgA, IgD, IgE, IgG, IgM. Wow. IgE is the big one that I want you to make sure you remember, because IgE is the one that's responsible for an immune response. Okay, so it's part of the anaphylactic response. Now, the humoral response begins with the exposure of the body to an antigen. Now, an antigen is any substance that's capable of inducing an immune response. Most of these antigens are proteins, right? They're simple proteins. You get an exposure to an antigen. After you have the exposure to antigen, the antibodies are then released from the cells, from the immune system, and then these antibodies physically attach themselves to the invading substance and then basically tag it so that the immune system can come in, gobble it up, and get rid of it, okay? So there's a lot of different areas that you can see as far as how that ends up going. Now, if the body's never been exposed to a particular agent, the response of the immune system is different than that if it was previously exposed to a particular agent. And we'll get into that difference when we talk about primary response and secondary response. But I want to focus briefly here on the image that's on the screen. If you look at the pathophysiology of anaphylaxis, we have the beginning where there's an antigen or a foreign substance that the body's exposed to. Shellfish, medications they're allergic to, penicillin, bee stings, peanuts, whatever it might be. That's going to immediately begin to activate the immune system, and that immune system is going to target those antigens through immunoglobulin E's, IgEs, right? Remember, those IgEs are responsible for the anaphylactic response. Now, what happens is when that occurs and we get the immunoglobulins there is a release and activation of histamine. There's an activation of SRSAs, prostatin glandins, and then complement and kinins. long story short, what does that mean? It causes a whole lot of problems. These cells are going to begin to start to break open. They're going to go through a process of lysing open, where they burst open, and when they do that, they're going to be releasing a significant amount of histamine along with heparin. Those are probably the most two common components that you're going to see that are there. You're going to have mast cells that are going to get there. They go through a process of degranulation. We'll get into some of that here in a second. But it's a cascading effect. So when the release of histamine, which is the predominant factor we're worried about, it causes a lot of different things. Number one, histamine increases capillary permeability. It makes the capillaries leaky, so that the plasma is no longer able to stay inside the vessel. It moves extracellular, right? Or it moves extravascular, I should say, outside of the vessel, leading to tissue swelling or edema, a common thing we see in an anaphylactic reaction. We know that that increase in capillary permeability leads to that third spacing or extravasation of the intravascular fluids. So what does that do? It's two factors. Number one is we get edema. We talked about that. Number of different types of edema. We'll get into that in a moment. And then we also see relative hypovolemia. The blood and volume, right, the liquid plasma that was inside the circulatory system is now moved out of the circulatory system into the tissue, leading to that edema. Well, that relative hypovolemia leads to a decrease in cardiac output. Decrease in cardiac output means a decrease in perfusion. We also see a decrease in the tissue perfusion, impaired cellular function because it's no longer having adequate oxygen to continue its normal anaerobic metabolism, moves to a form of anaerobic metabolism, which impairs cell function and then leads to cell death. Pretty big deal, right? So that increase in capillary permeability caused by that histamine release is a critical aspect of this. Hence the reason why we need to make sure that we stop the permeability of the capillaries, and then we do everything in our ability to get that histamine out of the system to prevent that leaky capillary syndrome from progressing or getting any worse. Second component, we see peripheral vasodilation. That doesn't help with maintaining a blood pressure, right? So if we have an increase in vasodilation, the pressure inside the vessels will drop. That leads to a decrease in peripheral vascular resistance. Remember, when you're dealing with things like cardiac output, part of that has to do with heart rate times stroke volume, and then the resistance, the peripheral vascular resistance that the heart has to work against. If there's a decrease in peripheral vascular resistance, the pressure that's going to move the blood and all the components of the circulatory system around the body are going to be impaired. So you're going to see, again, major problems with massive vasodilation and in more of a truly distributive form of shock. The last is going to be the constriction of extravascular smooth muscles. And this one, sometimes people go, that's not that important. You know, it's really about the histamine. It's really about the peripheral vasodilation. That's what's leading to signs and symptoms of shock. But one of the common signs that I've seen in my career for an anaphylactic reaction is oftentimes something as simple as someone who has an urge to defecate, or maybe they already have, and that may be the only thing that they're suffering from at the time is GI distress, and they're also dealing with maybe some shortness of breath. They haven't fully developed hives or urticaria that we would expect with a true anaphylactic reaction at that point in time. So what does that mean? Well, the constriction of the extravascular smooth muscles means it's going to increase the GI system. So you're going to see things like abdominal cramping, diarrhea, and vomiting. I've had calls where specifically I've got there and the guy said he was potentially stung by a bee, but he had defecated his pants. And the partner I was with didn't think it was an allergic reaction. I said, I bet money it is. We gave him some epi, 0.5 milligrams of epi 1 in 1,000 IM, along with 50 milligrams of diphenhydramine, Benadryl IV, and he was fine. He made a complete turnaround. But he did not have hives. He did not have swelling of his face or angioedema. He didn't have any of those symptoms other than GI distress. So remember, that does play a major role into this as well. The other thing that you're going to run into is how it affects the respiratory system. Because again, we know the smooth muscles are wrapping in the circumference of the lower airways. And then we know that we're leading to edema. We're going to see things like laryngoedema. That's not good. Swelling of your larynx is never a good thing as far as air going in and out. And then we also know that we can get bronchoconstriction, which leads to things like wheezing or airway constriction. So we end up getting a true major three-portion process to this. We get an increase in capillary permeability, leads to edema and third spacing of fluid, relative hypovolemia. We get a decrease in peripheral vascular resistance, so that's going to drop our blood pressure even more. And then we have issues where the patients may have distracting injuries such as GI-related problems, and then even more importantly, their airway is going to be impacted because of those smooth muscles, leading to laryngoedema and then also those bronchoconstrictions. So a lot of this is a really big chain effect, but it can happen so quick that we have to recognize it early and be very aggressive with our overall treatment. So if we think about some of these major components here, if we think about the immune system and how we talk about cellular immunity and humoral immunity, it's important that we kind of have a good understanding function of how a lot of this seems to function. So if I think about cellular immunity, it's a direct attack on the foreign substances by specialized cells in the immune system, right? These are things that you would see for anybody. In essence, it's going to be basically a process where you get a cold, your body's going to be able to fight it off, it's going to do what it needs to get that debris and byproducts of whatever that substance is out of the system and handle it at a cellular level. Humoral immunity is a chemical attack of the invading substances. This is where we're dealing with allergic reactions and anaphylaxis. And again, as we talked about, those primary components of those chemical agents are going to be those immunoglobulins, or those antibodies. I always like to talk about antibodies as ninjas, little kick-ass ninjas, because they are specialized to come and attack invading substances that are there. They also are interesting because they have a memory. They remember what was there. They prepare for it. They have an exposure. They overcome it. They're going to store and save those chemical components, those antibodies, and allow for them to come back later. So initially, you're going to have an initial attack, and then you're going to find that it's going to remember that, so that the next time there's an exposure, it can have an overwhelming impact on that invading substance. Downside is sometimes that antibody release, or the immunoglobulins, the IgEs in that case, are going to have a massive impact on a lot of major functions of the body, and that can lead to some problems, again, with anaphylaxis. So we know antibodies are manufactured by specialized cells of the immune cells. They're called B cells. They're the primary 5 classes of antibodies. We talked about IgAs, IgGs, IgEs. Those are the big ones for allergic reactions, IgGs and IgMs. And then the humoral immune response begins with an exposure of the body to an antigen. There has to be some type of exposure in order to trigger that humoral immune response. Now, if we start to think about these different aspects that we deal with in our process, we've got to think about what are these substances that actually activate the response. Again, an antigen is any substance capable of inducing an immune response. From viruses to toxins to carcinogens to fungi to pollution to germs to parasites to bacteria to any foreign substance in the body that can have a major impact. Now we know most of the immune system antigens are proteins. They're going to, after exposure, you're going to find that the antibodies are released. They're going to attach themselves to the invading substance, basically flagging it for the immune system to come in and to alleviate those major components. All right, so now let's start talking about different types of immune response, because this oftentimes can be confusing to folks because there's primary and secondary. Now, if the body has never been exposed to a particular antigen, the response of the immune system is different than it has ever been previously exposed to that particular antigen, right? So if it hasn't seen it, it's going to have a different type of response. The initial response that you see to an antigen is called a primary response, just like it sounds. So following an exposure to a new antigen, several days are required before both cellular and humoral components of the immune system respond. We see some generalized antibodies, so these are your IgGs and IgMs, that are first released to help fight off this antigen. Okay. Now at the same time, other components of the immune system are going to begin to develop specific antibodies for that antigen, right? Those little kick-ass ninjas are starting to think about what's going on. They're remembering. They want to come back so they can have a more aggressive attack the next time that there's an exposure. Now these cells develop a memory of that particular antigen. The body is exposed to the same antigen, if the body is exposed to the same antigen again, the immune system will respond much, much faster. Okay? This is called a secondary response. And as part of the secondary response, antibodies specific for the offending agent are released. These antigen-specific ninjas are going to be able to come in and be much more effective at facilitating the removal of that offending agent than the generalized antibodies, IgGs and IgMs, that you would see released during the initial or primary immune response. So what does that mean? The primary response is where the body is going to say, oh, gravy, good gravy, oh my gosh, what is this? I don't know what to do. I better start to sending my general antibodies just to see what's going on, or IgGs and IgMs. The secondary response goes, you know what, I remember you from the last time, and we've got our ninjas ready to go. We're going to kick into this, and we're going to make sure that everything ends up working very specific towards those components that we remember. So I know what you did last time. I'm going to come after you with full force to be able to make sure that you get that antibody and an exposure or antigen out of the system. All right, so let's start talking a little bit more about the immune system. So when we think about the immune system, again, we talked about that primary response is the initial response to the antigen. Generally, you're going to see that primary response is going to take several days, like we talked about, and it's going to be those generic antibodies that are going to be released, and those are IgGs and IgMs. It takes a long time for that to be able to take effect. Now, the secondary response is a much faster because antibodies have already been created to attack that offending agent, and they are released, and they are much more effective. However, oftentimes you can lead to issues where the antigen-specific antibodies can lead to a more pronounced reaction and definitely more systematic, system-wide. Now, if we think about immunities, immunities can either be natural or acquired, okay? Natural immunities are also called innate immunities, and these are generally predetermined. What does that mean? Well, that means that they are present at birth and that there has been no relation to a previous exposure of that particular antigens. We know that all humans are born with some form of antibodies, right? Some innate immunity that already exists that helps us protect our body from invading pathogens or antigens. Now, we also have what is called acquired immunity. Acquired immunity develops over a period of time, and it's from a result of an exposure to an antigen. So when you have an exposure to a particular antigen, the immune system is going to produce those antibodies for that specific antigen. That's how they retain that information, so they have a more direct impact later on. And so this protects the organism as subsequent exposure to the same antigen will result in a vigorous immune response. So it allows for us to be able to make sure that that's where we're at. We know that we've got the acquired immunity. We know that we've got the natural immunity as well. Now, the natural acquired immunity normally begins to develop after birth, and it continuously gets enhanced as they're exposed to new antigens and pathogens throughout life, right? So, for example, a kid gets chickenpox, varicella, at the age of 18 months. Following that infection, the child's immune system is going to create specific antibodies for that varicella virus. In essence, it allows for them to be able to be more protected if they were to have a repeat exposure. They're not normally going to get another infection because the immune system can suppress that, so we don't end up having an infection that leads to chickenpox, right? Now, usually you're going to see where if a patient's exposed to varicella, like chickenpox, they're going to have a lifelong immunity, but not always is that maintained. You may, for example, have to get what's referred to as a titer. It's a blood draw where they actually look to see what physical antibodies are available and is there enough of those antibodies available to ensure that you are protected. If not, you typically require to get a booster. That's not uncommon for us to have to get specific boosters for varicella. Even though you may have had it, it may not be enough to protect you over a period of time as your body will slowly lose some of those capabilities as it doesn't use it. Now, with naturally acquired immunities, we talked about that again already. I think we're good there. But now let's get into induced active immunity. That's the big one I wanted to focus on next. These are also called artificially acquired immunities. These are vaccinations, right? So when we think about your immune system, you have some that you're born with, right? Those are going to be the ones that are natural immunities. Your acquired immunities are going to be the ones that basically you're exposed to. That's where you generally will have those naturally acquired immunity examples. And then we also then lead into induced active immunities, which are vaccinations. These are artificially acquired immunities. They're designed to protect an individual from exposure to an antigen at some point in the future. This is why vaccines are so critical for eradicating or eliminating disease processes like polio or whooping cough or rubella, measles, mumps, those things we don't see routinely anymore because children are vaccinated at a very young age for that. Now these vaccinations, in the vaccination, the antigen is injected to the body and it does generate an immune response. This result is in the response to the development of the specific antibodies for that antigen and provides protection against future infections. Now, most vaccines contain an an antigenic proteins from a particular virus or bacterium. What does it mean? Basically, they're chopped up dead pieces of the virus. So you don't when you generally get a vaccine, you are getting a weakened or partial an exposure that really won't pose a threat or challenge to the immune system. You're going to have that initial response, but the immune system is easily going to be able to take it on, to kick its butt, and then it will remember it for future infections to prevent that as it creates additional antibodies. Your DPT or diphtheria, pertussis, and tetanus vaccine are common ones that you can see. Basically, it protects from the bacteria that causes things like diphtheria, whooping cough, and tetanus. So some of those common ones that you can see that are there. Now, those immune things, induced active immunities, oftentimes may not last for very long. So sometimes we have to, even though we've gotten a vaccine, you may have to go back and get a booster to make sure that you continuously have an appropriate amount of antibodies in order to fight off a future infection. So again, we know that most vaccines contain antigenic proteins from particular viruses or bacterium. We talked about that. And then a lot of times you're going to have to get a booster dose. For example, with your hepatitis B, it's a 3-shot series. You end up getting your first one, you come back a couple weeks later, or a month later, I want to say, and then at that point, you go ahead and go back 3 months after that to get your third final shot. At that point, you should have had enough to maintain that level of immunity. Okay. Now, the other aspect we looked at in regards to acquired immunity is that it can either be active or passive in nature. Active immunity occurs following the exposure to an antigen and results in the production of antibodies specific for that individualized antigen. Most of the vaccinations result in the development of an active immunity, although it can take a lot of time for a patient to be able to develop specific antibodies. And in certain cases, you may see where patients are going to be able to get antibodies provided to them that will provide some protection in a temporary phase until an active immunity can actually kick in. This is one of the core components we're seeing now with the use of Regeneron infusions for COVID-19 individuals, depending on the type of infection and variant that they have been exposed to or have contracted. Now, in addition to that, we're also going to know that the administration of antibodies can be referred to as passive immunity. Now, there are 2 types of passive immunities. Most of these passive immunities that you're going to see are going to be naturally passive immunities or induced passive immunities. Your initial component that you're going to look at for passive immunities and or natural immunities are going to occur when antibodies cross the placental barrier. They come from mom and they provide protection against the embryonic or the fetal-like infections. Induced passive immunity is the administration of antibodies to an individual to help fight an infection or prevent a disease. So naturally passive immunities we're talking about, they come from mom across the blood placental barrier, and then induced passive immunities is where they're going to be actually given antibodies to help fight an infection. A tetanus booster is an example of that. The COVID-19 vaccination, not the vaccination, but the Regeneron antibody infusion. Those are examples of induced passive immunities. So let's talk about allergies for a little bit. Allergies are different than that of an allergic reaction or anaphylaxis. The initial exposure of an individual to an antigen is referred to as sensitization. Sensitization results in an immune response. In essence, it's that subsequent exposures induce a much stronger secondary response. So what does that mean? Well, some individuals can become hypersensitive or overly sensitive to a particular antigen. Oftentimes you're going to see things like hypersensitivity, where they're going to have an unexpected or exaggerated reaction to a particular antigen. In many of these instances, hypersensitivity is used synonymously with the term an allergy, right? But there are 2 types of hypersensitivity reactions, a delayed and an immediate. Now, the delayed results in a cellular immunity, as a result of cellular immunity, and does not involve antibodies. It typically occurs in days or hours following the exposure. Again, you're going to see these predominantly used with your IgGs and IgMs. You also have an immediate hypersensitivity as well, too. Now, the delayed hypersensitivity is a result of cellular immunity, and therefore it does not involve those antibodies, which we talked about earlier. There is a delay in the normal process that occurs, typically taking those days to hours for it to be able to sort out the reaction for folks that are healthy generally. And then we have delayed hypersensitivity, which is most commonly a result of things like a skin rash, often due to an exposure to certain drugs or chemicals, right? And the rash that's associated with poison ivy is an example of a delayed hypersensitivity. So you get exposed to poison ivy, you don't immediately have a reaction, but you do have a reaction over a period of days. Now, immediate hypersensitivity is a much different component. When people use the term allergy, they're also usually referring to a immediate hypersensitivity reaction. These immediate hypersensitivity reactions can include things like hay fever, drug allergies, food allergies, eczema, and asthma. Most of the people that have an allergic reaction tendency are going to be some of the folks that have those specific types of illnesses and underlying conditions. Most of these are going to be genetic. You're going to find they're going to be passed from parents to child, and they're going to be characterized by the presence of large quantities of those IgE antibodies for an allergic reaction or anaphylaxis. And then the antigen that causes the release of the IgE antibodies is referred to as the term allergen. And there's a lot of different examples of allergens that we see, right? Or allergies that we see. Drugs, food, additives, animals, insects, insect parts, believe it or not, fungi, molds, and even things like radiocontrast dye or IV dye. All those are going to be some issues and concerns that you'll see. Now, these allergens, again, it's an antigen that causes the release of those IgE antibodies, and we talked about a number of those major components that you can see that would lead to an allergen or a reaction. Now, allergens are going to be, they enter in through the body. You're going to find that they're going to come through a normal, predominant routes. You're going to find that the majority of these are going to be oral, inhalation, topical, injection, or envenomation. And the majority of anaphylactic reactions are solely based on injection or envenomation, right? We talked about the peritoneal administration of penicillin or the injection of some type of bee or wasp-like sting. For insect stings, they're the second most frequent cause of fatal anaphylactic reactions. Things like fire ants, wasps, yellow jackets, hornets, and honeybees are all common ones, but you'll see that envenomation aspect of it that plays a role. Now, when you have an exposure to a particular antigen, right, large quantities of IgE antibodies are going to be released. They're going to attach themselves to the membranes of basophils and mast cells. So once that happens, specialized cells of the immune system that contain chemicals that assist the immune response are going to be activated. When the allergen binds to the IgE, it attaches to the basophils and to the mast cells. These cells then release histamine and heparin along with other substances we talked about earlier into the surrounding tissue. That leads to a lot of problems. When these mast cells and basophils degranulate, right, when they burst open, they're going to have this whole significant release of that heparin and histamine, and that's going to lead to that systemic effects we see of edema, relative hypovolemia, bronchoconstriction, excessive active smooth muscles, drop in blood pressure because of a reduction in peripheral vascular resistance. All of those things play a major role into this. Now, again, the cells are going to release predominantly two major components, histamine and the heparin. Histamine makes your capillaries leaky and moves that fluid from the vascular system into the tissue. Heparin is going to make it so that it's going to be harder for the body to be able to function as it normally does. And then there's other substances that go through that. Now, that process that we're talking about of releasing these substances from the cell is called degranulation, and this release results in what people call an allergic reaction, and it's really truly a scale of allergic reaction because it can be anywhere from mild to severe. Now, the principal chemical mediator for that reaction, as we talked about, is histamine. It minimizes the body's exposure to the agent, the antigen. It's basically going to be there, and it's trying to get what's in there out of the vascular system so it can't cause as many problems. We know that histamine is a very potent substance. It causes bronchoconstriction, increased intestinal mobility, vasodilation, increased vascular permeability, all those bad things that we don't want to see. So that's where we're going to see the medication of use of an antihistamine, Benadryl, for example, or diphenhydramine, that will assist with that. But it's important to recognize that even though we have excessive histamine in the system, just giving Benadryl alone is not going to stop the production of histamine. Histamine is being caused by those reactions to that exposure to the antigen. And so we must stop the production of that reaction through the use of epinephrine, of our Epi 1 in 1,000, 0.3 to 0.5 milligrams IM. That will stop the production and this degranulation process. At that point, we can begin to administer diphenhydramine. The diphenhydramine, once the reaction is stopped by Epi, we then can use that antihistamine to get that remaining histamine out of the system, so those compounding effects, because of that histamine being in the throughout the circulatory system, can now be mitigated to hopefully allow for that balance. So remember, Epi will stop the reaction. Diphenhydramine, Benadryl, will get the excessive histamine out of the system to prevent the progression of the reaction. So let's get into a little bit more here when it comes to anaphylaxis. We talked about this briefly, but we know that anaphylaxis occurs when a specific antigen is injected directly into the circulation. This is the reason that anaphylaxis is more common following injections of drugs and diagnostic agents and following bee stings. Now, when the allergen enters into the circulatory system, it's going to be distributed widely throughout the body, hence the reason why we see the form of distributed-like shock. The allergen interacts with both basophils and mast cells, resulting in the dumping of both histamine and other substances that are associated with anaphylaxis. Now, the principal body system affected by anaphylaxis is the cardiovascular system, the respiratory system, the gastrointestinal system, and obviously the integumentary system, or the skin. We also know that histamine causes a widespread vasodilation. That widespread vasodilation is important for us to recognize that that's going to make it hard for patients to maintain a blood pressure. It's going to lead to the issues where we deal with anaphylactic shock, or a distributed form of shock. Generally, people sustaining anaphylaxis for a period of time can actually die from circulatory related shock because the body can't maintain because of the increase in capillary permeability. Now, the other thing that we get is the release of basophils and mast cell substances, which are called slow-reacting substances of anaphylaxis, or SRSA. This causes a spasm of the bronchial smooth muscles. It results in like an asthma attack-type symptoms, and occasionally even asphyxia if it's left untreated. The SRSA potentiates the effects of the histamine, and especially has a major impact on the respiratory system, as we talked about previously. The biggest concern about this is that basophils and mast cells, when they slice open, they're going to be really leading to a lot of problems with the constriction of those extravascular smooth muscles. And that, to me, is a major concern. Remember, no airway, no patient. So we know that the signs and symptoms of an anaphylactic reaction can begin as quickly as 30 seconds. We know that when this is going to occur, the severity is really going to be related to the speed of onset. So we want to make sure that we're recognizing as quick as we can what the severity of the reaction is in relation to the speed of onset. The reactions can really happen in a very different spectrum, but you're generally going to see it very quickly, and the faster of the onset, the quicker the onset, the more concerning and severe the reaction is likely to be. So what do we look at when we think about our assessment aspects? Well, number one is your patients oftentimes who are having an allergic reaction are going to have this sense of impending doom, right? They get that first, and then they start to begin these additional symptoms. Maybe just some GI-related issues or some shortness of breath, but they haven't developed any type of angioedema, laryngoedema, or significant urticaria throughout the body. Now, it is possible, if it's possible, get a quick brief history including any type of previous allergies or exposures or reactions, and then make sure you quickly evaluate their level of consciousness. Remember that this progresses very quickly, 30 to 60 seconds. They can be unconscious, so we have to try to recognize that. We also have to recognize there's some common manifestations of angioneurotic edema. This is where it's involving the face and the neck. Oftentimes you'll see a laryngoedema, which is going to be a major issue for your airway. But this is the core component that we're trying to focus on here is going to be that we need to make sure that these folks get immediate attention as quick as they possibly can. We don't want to lose an airway in this patient before we even have a chance to establish one. Now, when we think about respiratory system, it's obviously involved in the anaphylactic reaction. We're going to see tachypnea, lower airway edema, bronchospasms, labored respirations, wheezing, diminished lung sounds, so on. All of these are going to be major concerns when it comes to your overall patient and their stability. How long do you have to be able to treat this? How aggressive do you need to be with your care? We also know that we can see a fine red rash that appears diffusely on the skin. This is typically referred to as just a generalized skin rash, and it can progress into urticaria or hives. Oftentimes people think these are big bumps or blister-like. They're typically not. They're more of like a wheal or flared-like reaction. They're red, they're slightly elevated, but they're not blisters. They're just going to generally be a rash. You're also going to find that urticaria or hives are going to be located in the areas of the body that are the warmest. Armpits, groins, and chest and back, abdomen as well. Those core areas have more heat, they have higher levels of circulation, so you're likely to see hives develop in those areas. You don't see hives develop on your hands and arms as quickly as you will on the warmer areas of the body. So it's important to make sure that you do a good physical assessment to expose your patient to see if they have any type of centralized urticaria. We know cardiovascular collapse along with dyspnea will progress, and if the patient will become typically pretty diaphoretic, and if they're left untreated, they're going to end up getting very hypoxic. You're going to see signs of cyanosis and pallor. We know that histamine has a major effect on the gastrointestinal system, as we talked about. Nausea, vomiting, diarrhea, very common. And vital signs are going to vary based on the severity of the reaction and the stage of the reaction. If it's an allergen, an allergic, or if it's an anaphylactic-like reaction. Remember, an allergic reaction can be anywhere between mild to moderately severe. Anaphylaxis is a true life-threatening related issue. And again, we're focusing on the core things, ABCs, respirations, heart rate, and then any other ominous findings we might see. We've got to make sure that we're monitoring our patient closely. We need to make sure we establish an airway, that we maintain adequate breathing. That's our minute volume, rate, and tidal volume. We also want to make sure that we're monitoring for hypoxia and hypercarbia. So that means that we need to make sure that we're administering oxygen when it's necessary. We want to avoid hyperoxia, but it's pretty rare in an anaphylactic case to have hyperoxia when their airway is swelling shut. We also want to make sure that we consider the use of end-tidal capnography, because it's going to help us determine, are they dealing with some type of metabolic acidosis or respiratory acidosis or a combination thereof. We want to make sure your scene is safe. Remember, if what's ever caused their reaction could be a problem that you are exposed to as well, right? You end up getting someone who's attacked by bees. Is the scene safe? Are you able to go in, or are you going to be attacked by bees yourself? Or are you allergic to the same exposure that individual had? Those are concerns you have about safety. We also have to recognize that individuals that are stung by honeybees, the stingers left behind, you may have to take an ID card and scrape it parallel to the skin to be able to go ahead and get that stinger out. Again, with that stinger in place, it can continuously cause more of those antigens to be in place, and the body will have to respond to those. Always think about the possibility that there's trauma involved in any type of allergic-like reactions, and a lot of the symptoms may truly be masked by anaphylaxis. Maybe they got stung by a bee and then fell off of a ladder while cleaning their gutters. Now that's a traumatic and a medical component. We got to be able to go after both. For our management, most of the time with our management, you're going to be able to see it's pretty consistent based on the reaction itself. We're going to determine if the reaction is considered mild to severe. If the reaction is mild, we're going to see things like itching and rash and urticaria, but that's really about it. We're not going to see any signs of cardiovascular collapse, significant problems with breathing, generalized edema, and so on. For these cases, you're going to go ahead and administer oxygen to your patient based on the core component of 100% of O2, making sure that your monitors are in place to prevent excessive hyperoxia if possible. Typically, that's not the case. You're also going to go ahead and consider the use of epinephrine 1 in 1,000, that 0.3 to 0.5 milligrams IM. That's going to be given every 3 to 5 minutes, or probably every 15 to 20 minutes. And then you're also going to consider antihistamines, things like diphenhydramine. Those can be given IM. They can also be given orally. They can also be given IV. And then you may want to consider some type of oral corticosteroids. A lot of times, these are the folks that may have to use an EpiPen. They go to the ER, they get taken care of, and they get released, and then life is okay. Now, if you're dealing with If you're dealing with a severe reaction, now you're getting into situations where you're dealing with severe upper airway edema, lower airway edema, GI signs, and symptoms of cardiovascular collapse. For high flow oxygen, we're talking about 100%, again, making sure we get IV or IO access, placing our monitors as necessary. And in this case, if we're seeing signs of cardiovascular collapse, where the patient no longer has an adequate blood pressure, in that case, you're going to want to go ahead and administer epi 1 in 10,000, 0.1 milligram over 5 minutes. This is going to be a process of giving a slow IV push. It's not very much of your epinephrine. It's a much higher concentration, but we're giving it IV because we want to make sure that our patient's circulatory system is functioning. If I stick a needle into their muscle, it's very unlikely in a circulatory collapse that that muscle is going to absorb that medication, epinephrine, into the generalized circulatory system. So that becomes a major overall concern. The second thing that you have is we want to make sure that it actually works. So with the higher concentration directly into the vessel at a smaller dose will help us alleviate a lot of those symptoms. We then consider IV antihistamines. We want to consider beta agonists, bronchodilators, there's bronchospasms. We also want to make sure that we consider corticosteroids, things like your solumedrol, to be able to truly affect and have an impact on those core symptoms, things that we may have a little bit later on. Again, we can consider if hypotension continues to persist, we may want to consider epi-push or epi-drip at 1 to 4 micrograms per minute. And then even glucagon, believe it or not, 1 to 2 milligrams every 5 minutes IV or IM for patients that are unresponsive to epi oftentimes can be very effective. If they're bradycardic, you want to consider atropine. Atropine is going to be an effective tool for us to be able to get those major components under control. So again, if suspicion of coinciding trauma, we want to make sure we think about C-spine, position the patient to make sure their airway is protected. Oxygen is important, provide ventilatory assistance, and remember, basic before advanced, but be aggressive with your medication therapy. You can use oral pharyngeals or nasal pharyngeals airways with caution because oftentimes these can lead to laryngospasms, just making the process of that inflammation and airway obstruction even higher. We also want to make sure that we consider endotracheal intubation early because we want to capture the airway before it seals shut from that edema. We also want to make sure we have equipment available in case we need to do some type of surgical or needle crank. Again, establish your IV as soon as possible with a crystalloid-like solution. Administer fluids at wide open if they're hypovolemic. You're going to do your 20 mLs per kilogram fluid bolus. And if time allows, place the second IV line in place. Medications, we talked about it. The predominant treatment is pharmacological. Oxygen is always the first drug of choice. Epi is your secondary. Remembering that Epi 1 and 1000 is our predominant route of 0.3 to 0.5 milligrams IM. And it is going to work relatively quickly. We're also going to go ahead and use the antihistamines as a second-line agent of getting those excessive histamines out of the system. Benadryl or diphenhydramine is your most common, and that's typically 25 to 50 milligrams IV or IM. Medications that you can continue to give as well are corticosteroids. These are important in the treatment and prevention of anaphylaxis. They help suppress the inflammatory response. And so that'll help eliminate any of that excessive edema that we see as part of that response. Vasopressors are another component you may have to consider: dopamine, norepi, epinephrine, epi-drips, epi-push, whatever it might be to help maintain that blood pressure support. We've got to have a blood pressure available for our patient. Beta agonists, again, these are going to be our to help reverse our bronchospasms. These include your albuterol or duolinib treatments. Anything that we're dealing with a specific bronchoconstriction that we want to try to reverse because we know those are very closely related to our anaphylactic patients. Other agents we talked about: vasopressin, atropine, and glucagon per that protocol. Again, provide that emotional support. They are going to be scared. Remember that you can aggressively reverse this if you're early in recognition and that you're conscious of where they're progressing and how quickly they're progressing, so your treatment's going to be done in a proper sequence to get the best bang for your buck. Remember, oxygen, epi, Benadryl. Those are going to be the most predominant ones, followed by additional components of pressor agents If we're dealing with circulatory collapse, there's no longer able to get a blood pressure, we're going to move to our 0.1 milligrams of epi 1 in 10,000 IV. So remember that with the allergic reactions, we're going to have generally a gradual onset with milder signs and symptoms than that compared to an anaphylactic reaction. These folks are going to typically be conscious, alert, have a normal mental status. So for a mild non-anaphylactic reactions, we're going to see itching and rashing and stuff like that. We're going to have some generalized comfort systems that we may need to put in place. We may want to give some antihistamine, some epinephrines, especially if we're seeing signs of, they feel like their throat is scratchy or they've got some urticaria. That's the case. Remember, anyone that's showing signs of airway-related issues, epi should be one of the drugs we give right away, epi 1 in 1,000. And then from there, supplemental oxygen and beta agonists to support as well too. For lesser allergic reactions, a lot of times you're going to see they're accompanied by hypotension or airway problems. Again, that's treated with the epi 1 in 1,000 IM. And then again, we can also give intramuscular route. Should not be used for those folks who are in severe anaphylaxis because it's not going to be absorbed through the muscle. We're dealing with that circulatory collapse. We have that increase in capillary permeability and that fluid shift. So putting medication into the tissue is not going to be an effective route to be absorbed. That's why it needs to be administered IV. And again, it's at the epi 1 in 10,000 concentration rather than the 1 in 1,000 you would give IM. We also know that we need to make sure we educate our patients because anaphylaxis is preventable. They just need to stay away from what they're exposed to. So that's important as an educational standpoint, especially for kids and then maybe for caregivers and things that may not be directly responsible for those individuals routinely. We also know that those who have a history of reactions should be educated about what they should be able to recognize and how to perform their own treatments, making sure they know that they should have and carry their own EpiPens. And then when they have severe reactions, they should be wearing identification bracelets, medical alert tags, something that would allow for them to be, the paramedics to be alerted that there is a potential for a reaction. Many patients with anaphylactic treatment, they're going to have their own home EpiPen. There's a lot of different types of EpiPens. Luckily, they're coming down in costs finally. But just because they gave themselves their own EpiPen doesn't mean that we're not going to need to provide additional care. It also means that we probably ought to transport them to the hospital to make sure that the reaction doesn't continue or get worse. Again, it's going to really have to do with the severity of the onset and the severity of the reaction. We want to recognize that oftentimes folks that continuously have these related issues, gradually they're going to increase to the point where anaphylactic reactions can be averted if they have a significant exposure. Problem is, we don't want to expose them excessively if it could kill them, but naturally, if they're exposed enough, it may actually allow for them to have some of those reactions that are averted. We have to keep reference cards for anaphylaxis patients in our service area. If you know you've got a really bad allergy to a specific patient, hopefully it'll be in their dispatch notes, but it's going to allow for us to get that information. So if you've been on these patients before, you want to recognize that how their previous reaction occurred, the swiftness of it, and their response to treatments. And remember that because that can truly help us identify and have better interventions earlier on for better outcomes for that individual. So in summary, we know that severe allergic allergies and anaphylaxis are uncommon, but when they do occur, they progress quickly and they can immediately lead to death within minutes. We're talking about 30 to 60 seconds where they can be in a full, true anaphylactic-like reaction. We know that central physiological attention to anaphylaxis is based on that massive release of histamine and heparin. We know histamine is the major problem causer of bronchospasms, airway edema, peripheral vasodilation, and the increase in capillary permeability. All of that's going to lead to relative hypovolemia. All of that's going to lead to the constriction of the bronchioles and edema throughout the body, along with the loss of peripheral vascular resistance. We know that we need to make sure that we're using the primary treatment for, even though that we know Benadryl and the antihistamines are important to get rid of those histamines that are causing the problems, epinephrine is going to be what helps reverse the effects of the histamine. It stops the production. At that point, we can then go ahead and give an antihistamine to alleviate that excessive histamine out of the system. Remember that it's going to help support blood pressure, and it also is going to reverse some of those detrimental capillary leakage that we have as well too. And we want to recognize that after we give epi, we really should be going and giving that antihistamine Benadryl to block any of those massive effects because of that histamine release. We know that inhaled beta agonists are useful in severe bronchospasms, and like obviously we know that the allergic reactions or anaphylaxis are definitely going to involve the airways, so we want to recognize that and be aggressive when it comes to the use of our beta agonists. We also know that IV fluid replacement is crucial in preventing hypovolemia and relative hypotension, so make sure that you're administering the proper fluid bolus and consider the use of those pressor agents, or epi, your norepi, your dopamine, dobutamine, push-dose epi, whatever it might be to help maintain that blood pressure. Last but not least, the key to success of pre-hospital management of anaphylaxis is prompt recognition and treatment. I can't reiterate that enough. That is a major portion of this, is recognizing the signs and symptoms and being aggressive with your overall care. I hope that this presentation was helpful for you. And again, as we go forward, make sure that you're continuously focusing on those core treatment algorithms, making sure that you're focusing in the early recognition, because truly it can make the difference between life and death. Hope you guys enjoyed this quick lesson. We'll catch you guys on the next one. Have a great day.